Hi y'all, and welcome back to Professor Truelove's Concepts for Nurses series, and I am Professor Terry Truelove. And in this episode, part of the Respiratory series, we're going to be looking at tracheal tubes, that is, the care of both endotracheal and tracheotomy tubes. Sources for this episode include Iggy's Medical Surgical Nursing and Sol's Introduction to Critical Care Nursing. The first type of tracheal tube we'll be looking at are endotracheal tubes. These are intended for short-term, that is, less than 2-week use for airway protection and as a way to properly ventilate a patient who requires ventilatory assistance, and they can be placed either orally or nasally. And the size used depends on the size of the patient, the anatomy of the patient, the type of trauma or disease that the patient has. Placement is confirmed by auscultation, that is, making sure left and right-sided breath sounds are equal. Also by chest x-ray and capnography. You should secure the endotracheal tube with commercial devices or tapes. I will discuss endotracheal tubes further in the critical care episode. For now, you need to equate them with many of the features of tracheotomy tubes because they share commonalities and there's also a few differences. One of the differences is the amount of time that these tubes should stay in. Now, tracheotomy tubes are disposable or reusable. They may either be cuffed or non-cuffed for airway maintenance. The inner cannula is disposable or reusable, and sometimes there is an extra opening called a fenestration to allow for vocal communication. In a nutshell, the difference between an endotracheal tube and a tracheotomy tube is the length of time they're going to be left in. And although there is no hard time set for how long an endotracheal tube can stay in, because the answer is it can stay in for the longest of times as long as there's no tissue damage, the rule of thumb is generally after about 2 weeks, you're looking to replace an endotracheal tube with the more permanent tracheotomy tubes. There's advantages and disadvantages to both the endotracheal tube and the tracheotomy tubes. For instance, endotracheal tubes do not require the traumatic insertion that a tracheotomy does. However, tracheotomies allow for easier communication and are more comfortable. You need to differentiate between a tracheotomy and a tracheostomy, because the tracheotomy is the surgical incision into the trachea for the purpose of establishing an airway, whereas the tracheostomy is the opening or stoma that results from the tracheotomy surgery. By the way, they may be temporary or they may be permanent, again, depending on the patient's condition. Complications associated with tracheal intubation include pneumothorax, subcutaneous emphysema, bleeding, infection, and trauma. And complications from placing an endotracheal tube include right mainstem intubation or esophageal, that is, gastric intubation, instead of intubation into the trachea. This illustration demonstrates the sniffing position, an ideal way to not only visualize the vocal cords for intubation, but to maintain the airway as straight as possible. On the right side, it is an example of an endotracheal tube. Note that in the middle is the balloon for the cuff at the end of the endotracheal tube. That cuff not only helps to maintain a seal to provide for ventilation, but also that seal prevents aspiration of outside stuff, like gastric contents, into the airway. This illustration demonstrates the various types of tracheotomy tubes that are available. Notice a couple of things. You have a fenestrated tracheal tube here. You have an obturator, which is a way to introduce or maintain the tracheotomy. You have semi-permanent and permanent displays, and also notice the high volume, low pressure cuffs that are very evident here that are found both on endotracheal tubes and tracheotomy tubes. And this is a way to maintain a seal without necessarily causing too much trauma to the airway mucosa. Despite this, these cuffs can cause mucosal ischemia. So a couple of techniques that are used to minimize this include the minimal leak technique and the occlusive technique. Minimal leak technique is used with positive pressure ventilation. And the idea is to get just enough pressure on the cuff so that when the highest pressure from the delivery device occurs, there's a minimal amount of leaking that occurs around the cuff, always outward, always towards the patient mouth. This assures that the patient will not aspirate, but demonstrates that we're using the lowest possible pressure to keep the cuff inflated. You should, with the respiratory therapist, check the cuff pressure often, prevent tube friction by preventing movement, and prevent or treat malnutrition, hemodynamic instability, and especially hypoxia. The structure of tracheal airways prevents the person from naturally expectorating the mucosal secretions that will build up. Therefore, they need to be suctioned. That is, a smaller catheter needs to be put into that endotracheal tube or tracheotomy in order to retrieve, that is, suction out the mucus. However, this action can cause the patient to have hypoxia. So causes of hypoxia with tracheal intubation include ineffective oxygenation before, during, or after suctioning, a use of the catheter that is too large for the artificial airway when suctioning, a prolonged suctioning time, excessive suctioning pressure, and suctioning too frequently. During suctioning, an assessment should be done of the endotracheal tube or the tracheotomy tube. When caring for the ET tube, assess for mucosal injury, particularly around the oral or nasal area where the tube may be in contact with tissue. Assure for proper placement, and that means you should observe and document the centimeter depth markings that are on the side of every endotracheal tube. You should provide for frequent, that is, at least every 2 hours, oral care, and assess the cuff pressure for proper security, and work with an RT to make sure you have proper pressure. Tracheotomy care requires the same amount of diligence. So assess the patient, make sure that you secure the tracheotomy tube with commercially designed fasteners like those shown here, and work hard to prevent accidental decannulation. This could be an emergency, particularly if your patient is requiring ventilatory assistance, because that is where the ventilator hooks up to. It is important that whether the patient is endotracheally intubated or has a tracheotomy in place, that they are being supplied with warm, humidified gas. And this is because they require air warming and humidification. Endotracheal tubes and tracheotomy tubes bypass the nose and mouth, which normally humidify, warm, and filter the air. Therefore, the air being delivered to the patient must be humidified at the proper temperature, about 100 degrees Fahrenheit, 37 degrees Celsius, and you should ensure that the patient themselves are receiving adequate hydration, either through oral means or through intravenous means. This humidity will require suctioning, which we discussed earlier. So, to review, this maintains a patent airway. It does promote gas exchange. Assess the need for patients who cannot cough adequately, whether they're intubated or not intubated. You may have to retrieve that mucus by suctioning, and you will use a closed system if the patient has a closed ventilatory system because they're on a ventilator, or an open system if they're just using something like a T-piece or a tracheal mask. Besides the hypoxia mentioned earlier, suctioning can also cause tissue trauma. Because the inside of the airway is supposed to be sterile, the introduction of this device can introduce bacteria, causing infection. You can induce vagal stimulation and bronchospasm, and because of induced hypoxia, cardiac dysrhythmias might be noted. Therefore, it is important that you do everything you can to help promote proper removal of secretions, and that means bronchial and oral hygiene. You should turn or reposition the patient every 1 to 2 hours, support out-of-bed activities, and encourage early ambulation. For the patient who is extubated, coughing and deep breathing, chest percussion, vibration, and postural drainage promote pulmonary care. For both intubated and non-intubated patients, you should avoid glycerin swabs or mouthwashes containing alcohol for oral care. And this is because these are known to dry out the mucosa. Assess for ulcers, look for bacterial and fungal growth, and other signs that indicate the patient's mucosa or airway may be infected. As you might imagine, the physical location of these tubes will interfere with nutrition. So swallowing can be a major problem for patients with tracheostomy tube, and swallowing with an endotracheal tube puts the patient at risk for aspiration and is highly discouraged. I would say maybe even contraindicated. If the balloon is inflated, this can interfere with the passage of food through the esophagus. So it's important that the nurse who has a patient who's doing oral intake has the head of the bed elevated for at least 30 minutes after eating to prevent aspiration during swallowing. And the nurse may need to consider enteral or percutaneous tube feeding for long-term intubation or for the patient who is or has an endotracheal tube in place. One of the terms you will hear when talking about intubation and ventilation is the term weaning. Now, a person can be weaned from the ventilator, that is, the amount of work done by the ventilator will be slowly reduced. However, there's another type of weaning that you should be aware of, and it's called weaning from a tracheostomy tube. This means that we're going to slowly change the size of the tracheostomy tube, reducing that size with the ultimate goal of completely removing the tracheostomy tube. So, the cuff is deflated when the patient can manage secretions and no longer needs assisted ventilation. At that point, we can change from a cuffed to an uncuffed tube. The size of the tube is decreased by capping. That is, a physical barrier is put above the normal opening so the patient can breathe around the tracheostomy tube, and you can use a smaller but fenestrated tube to maintain an open airway. However, a tracheostomy button has a potential danger of getting dislodged and aspirated. Weaning from the ventilator is going to be covered in a different episode. And that episode is coming, but not until we discuss other aspects of respiratory status. So that is the end of this episode. I hope you learned a little bit. I hope you plan on coming back, and if you do, I'll see you then. Take care now.